A nossa aula hoje é com o Dr. Shen, nosso grande amigo da Universidade de Colômbia, e o tema é Endoscopic Treatment of IBD. É necessário que vocês façam perguntas, vão fazer perguntas pelo chat, e assim que ele terminar a palestra, o Dr. Luiz Lobato, que é professor adjunto da Universidade Federal de Minas Gerais e ex-fellow da Cleveland Clinic de Ohio, vai moderar a mesa que o Dr. Shen está participando. Então, antes disso, eu vou apresentar para vocês o Dr. Shen. Vocês me desculpem, mas eu vou, para ele poder entender, eu vou falar em inglês para ele poder entender. 1 minute, Dr. Bo. First of all, I'd like to thank you for accepting my invitation to speak at this lecture. Thanks, Dr. Shen. But I'd like to say a few words about Dr. Shen. I can tell you he is a caring, generous man, not only to his patients, but also his colleagues. Due to his expertise in treating a wide range of pouch-related disorders, Dr. Shen is a world leader in IBD research and interventional IBD. He is the Vice Chair of Innovation in Medicine and Surgery, Professor of Medicine and Surgery, and Director of the IBD Center at Columbia, New York-Presbiterian Hospital. He is a brilliant professional. I am so happy to welcome Dr. Shen. Take it away, Dr. Shen.
Thank you, Magda. Can you guys hear me?
Yes.
Okay.
Yes.
Thank you, okay. And thank you, Luiz, and thank you, our Brazilian friend. And first of all, from the epicenter of a coronavirus in the United States, the peak is gone. We're happy, but our heart now are with our Brazilian friends. And as a matter of fact, every time I went to Brazil to have a conference, I really feel like at home. I'm so grateful to my friends there. Lots of the colorectal surgeons and IBD specialists, gastroenterologists. I just love you guys. And so please let us know if the coronavirus related or in the future IBD complication related medical issues or endoscopic issues, please feel free to contact us, or you can contact Magda, and Magda can send an email to me. And then so I joined Columbia 6 months ago, and Columbia is a great institution. And I really enjoy the work environment, collegiality, and our patients, patient care, and also enjoy the city. So move forward. So today's give me like 30 minutes. If I have time, I can go a little bit more about endoscopic management of IBD and IBD surgery associated complications. So let's see if it move to the next slide. So this slide is like a very well-known. So we call a step-up approach. When the initial phase of the disease, people do the mesalamine agent, then steroid, the immunosuppressive agent, and then later on, the last stage is the surgery. But the surgery, in majority of the patients, the disease is not done. The surgery issues mainly is post-surgical complication and post-surgical recurrence. So unlike the people had appendicitis or acute cholecystitis, you remove the gallbladder, you remove the appendix, you're done. But in IBD, typically you remove the part of the bowel, your disease is not done. So now, these are also very famous slides. Basically, at initial stage of the diagnosis, majority of the patient is inflammatory type. And then as the years goes by, and the majority of the patient later on develop various kind of the complication that including stricture, fistula, and abscesses. So that's leave there the medicine window period about 3 to 5 years at the initial diagnosis. So medicine, the purpose would be really wanted to prevent tissue damage and prevent this mechanical complication occur. Now, so many years ago, if you do the endoscopy, do a lot enough, you will see this is the many years ago, we see this as a Crohn's disease ulcer. You can see the ulcerated structure, Crohn's disease structure is ulcerated. You can see the ulcer here, you can see the ulcer here. But over last probably 10 years, we see and more those type of ulcer. No structure, no ulcer, but structure is non-ulcerated. So is this related to the disease or related to the treatment? I firmly believe the vast majority of the patient, they can achieve the mucosa healing, but the structure become non-ulcerated, but they're very tight. You could not pass the scope through it. So that's why it's like you translated this type of ulcerated structure to non-ulcerated structure. Now, even more so, even in ulcerative colitis patients, we see more and more ulcerative colitis patients with non-ulcerated structure. Typically, those patients have been on long-term biological use. Now, this is not only in Crohn's disease, but in ulcerative colitis. Now look at the component of a structure. You can see the ulceration, you can see the fibrosis, you can see the hypertrophy here of the muscle, and you can see the mucosa is intact, but underneath it, you can see the submucosal fibrosis. I show you another picture. Now, mucosa is normal, but you can see the muscular hypertrophy that can cause a structure. So here is like if the people have the muscular hypertrophy, neuronal hyperplasia, those are neuronal hyperplasia, neural fibers hyperplasia, and with a fat wrapping, this is Crohn's disease. That all can cause the stricture. So now this is the classic one. If there any audience has in the surgeon, be very careful about when you have a surgical resected specimen. Ask your pathologist comments that if you have a resected specimen in this neural hyperplasia, that is a prognostic sign. It's a probably worst prognostic sign. So if you have this in the surgical specimen, those patients have a high risk for disease recurrence. Very careful, disease recurrence. Now, there is the slogan said, no inflammation, no stricture. No stricture, no fistula. No fistula, no abscess. Here it's the artwork. If you have chronic inflammation, you can cause a stricture. And the stricture causes a prestenotic luminal dilatation, and the pressure zone causes a side tract, causes a fistula, and here is abscess. So in other words, if we can prevent inflammation or treat a stricture, you may decrease the risk for fistula and abscess formation. And this is a surgical specimen from my dear mentor, Dr. Vic Fazio. He's my hero. I want to use his to give my fond memory of him. Now today, actually, these slides I collected today. And this Jewish girl had psoas abscess here, and you can have the stricture here, prestenotic dilatation, and a fistula to the psoas muscle cause abscess. Now here is the drainage catheter. So no inflammation, no stricture. No stricture, no fistula. No fistula, no abscess. Now, where are we now in terms of the medical therapy? So far, we do not have any drug for antifibrosis. We do not have any drug to treat the muscle hypertrophy. We do not have any drug to treat neuronal hyperplasia. So if you do not have a medicine, dissolve the stricture, dissolve the blockage, and your only option is a mechanical. The mechanical way to treat either endoscopy or surgery. Now, this is a hidden slides, and a lot of the drug companies don't want us to show you, okay? But I listed here. So you look at all the publication, all the major trial in the publication, the Gut, New England Journal of Medicine, etc. Look at this Remicade, Humira, etc. All the medicines, right? Look at it has the exclusion criteria. Exclusion criteria, you know what? The patient with a stricture or blockage were all excluded. So that's why in the clinical trial, the result is very good. But in the reality, the result is not so good because you have seen those patients. When you enroll the clinical trial, those patients were excluded. Okay. Now, talk about Luiz. What's the surgeon's trick? The surgeon's trick, you either remove the part of the bowel and do the anastomosis, or you do the strictureplasty, or you drain the abscess. These are probably 3 common surgical procedure for Crohn's disease. Now, this is the famous slide. I should have point out. This is the before biologic era. Basically, majority of the patient after 5 years has either symptoms recurrence or endoscopic recurrence. So the surgery is not a cure. It is not a cure in majority of the patients. So after surgery, some of the patients still need a medicine. So now this is the one actually is a bloody lessons I want to share. Okay, this the patient had the ileocecal valve stricture. So I keep doing dilatation, and so let's see next slide. And then the patient has said, I'm tired of coming from Maryland to Cleveland. I just want a surgery. Now look at the structure, it's straight. I can use a balloon to stretch it. After surgery, now your structure become angulated. Now give me a harder time to treat. Actually, he went to the surgery for nothing. You make the original straight structure more difficult to treat endoscopically. That's extreme case. So the surgery has issues, and then of course endoscopic therapy has issue too. Now, many years ago, this related relic trial, I make some comments in terms of like how do you choose medical therapy and versus surgical therapy? You need to balance the risk and the benefit of the medical therapy and the surgical therapy. But however, when you do the risk stratification, please look at the 4 factors, okay? 4 items I showed all here. You need to assess the aggressive disease, the risk factor for aggressive disease and the poor prognosis. You need to assess the risk factor, who will be respond to medical therapy, who are not. You need to assess the risk factor if the patient did go to the surgery, what's the chance they will develop post-surgical complications. You also need to assess what's the chance or what's the risk factor after surgery the patient will have a disease recurrence. Okay, so 4 tiers risk stratification. Now, life like a cycle, you know. So most of the time we do the Crohn's disease, ulcerative colitis, we give the therapy. And you do the remission and the disease recur, or disease not recur, but chronic inflammation cause colitis associated neoplasia. Then you had a surgical therapy. And after surgical therapy, you know what? You have the post-surgical complications and you have the post-surgical recurrence. And then you started the medical therapy again. Now it's life like a circle. Now I position the endoscopic therapy to this 3 areas. First of all, we tried to prevent to have a surgery. So treat the mechanical complication stricture, or at least postpone or space out the need of the surgery. And then if they do have the surgical complication happen, at the endoscopy, we can help to treat these complications. But if the patient had a disease recurrence, we can endoscopy therapy can do something. If they recurrent the structure, we treat it again. Okay, now challenge the endoscopy in IBD, because a lot of the people they feel comfortable to the endoscopy, ultrasound, ERCP, point, etc., but not very comfortable to do IBD therapy. Why? Because people scared. Scared of what? First of all, IBD patient almost always has the underlying inflammation. And IBD patient bowel wall has no layered structure. So EUS endoscopy ultrasound won't help you. And most IBD patients on immunosuppressive therapy. And some of the IBD patients had the malnutrition, and some of the patients may already had the multiple surgery with altered bowel anatomy. And even some of the patients even have the short gut. Now, this is to tell you about the layered structure here. Left side is normal small bowel. You can see the mucosa and muscularis mucosae, submucosa, and muscularis propria. But here, you don't see any layer. Don't try to use the EUS to guide you. It won't be helpful. Okay? Now, so all the people, most of the audience in the past asked me, say, Dr. Shen, if you treated with a needle knife balloon, you stretched how deep? Deep would be like, say, your hand feeling. The hand feeling, when you do the therapy, you need to make sure the lumen, at least, you need to do at least of 2 centimeters in size, 2 centimeters. You need to pass the scope without resistance after treatment. Now, here is some area when you have treated IBD complication. There are certain areas, be very, very careful, okay? So I use the zone 3. For example, if your IBD esophagus, IBD in the duodenum, treated is very, very careful because the bowel wall is very thin. If you perforated the duodenum, a whole mess. If you have a fluid collection, liver abscess, very bad. If you perforated esophagus, you may have this called pneumomediastinal or mediastinitis, and it can kill. But however, the comfort zone, if you have IBD in pylorus, IBD in ileocecal valve area, and IBD in the rectum or IBD in the anus, is your safe zone and the comfort zone. You can give a lot of treatment. All those areas have the thick muscle. And the worst case, if they hear, let's say you have a complication called a perforation. Hey, you have the surgeon, it's like Luiz in the nearby. Say to call him, and then worst case would be stoma, 3 months. Worst case. There should not have any mortality associated with that. Okay, so what's the enemy? If the patient on corticosteroid, do not do anything, okay? If the patient on the prednisone, if you try to use a balloon dilatation, needle knife therapy, whatever, it easy cause of bleeding and perforation. Typically, if the prednisone dosage is more than 20 milligram a day, we should postpone or schedule the patient to have the procedure, endoscopic procedure. When you also do the procedure, you always have the second step or third step ready. Just in case there's a bleeding, there's a perforation, you can put a clip there to prevent the perforation. Now, so that now current indication for endoscopic therapy, I summarized it's a stricture, fistula, abscess, or surgical leak, and ablation and of the colitis associated neoplasia. So regarding the stricture therapy, so we did a consensus guideline, and I believe the Dr. Combs, Dr. Paulo Combs from Brazil, Curitiba, and is one of the members of the group. We reached the consensus guideline in terms of how do we do the Crohn's disease stricture endoscopic therapy in terms of the indication, precaution, etc. So we gathered a group of people together called Global Intervention IBD Group. So we published the guideline back in April. So now before you go to IBD stricture, and then, well, first of all, you need to classify the stricture. That's a very complicated classification system. Regarding the source of the stricture, is it intrinsic, extrinsic, clinical presentation, symptomatic, asymptomatic. Underlying disease can be IBD, can be primary or disease associated, or secondary in terms of anosmosis. You can have the malignant potential and the concurrent inflammation or fibrosis component, or mixed. Then also you can classify the important you here is for the treatment, it is the length of the stricture. So typically, if the stricture more than 5 centimeters long, we do not deliver an endoscopic therapy. So any stricture less than 4 to 5 centimeters long, we give it endoscopic try. And also important ones, the number of the stricture. If the more than 3 strictures, you probably need a surgery. If fewer than 3 surgery, you may do the endoscopic therapy first. And if the patient had a complex structure associated with a fistula and abscess with a pre-stenotic luminal dilatation, those patients you may consider have had surgery. So this I can show the picture of some of the classic the structure. The web-like structure result of the endoscopic therapy would be the best. And the ulcerated structure, typically we try avoid balloon dilatation, afraid of the bleeding. But this ulcerated structure, the area without ulcer, you can still use a needle to treat. And then this type of structure, we call a non-ulcerated structure, but a spindle-shaped, like a spindle-shaped structure. When you do the endoscopy, be very careful because the tissue there is very fragile. If you do the balloon dilatation, they easily get perforated. But if you really wanted to treat, try the needle knife or insulated tip knife, not the balloon, this type of structure. Those structures typically results from the long-term use of the biologic agent. Now you have inflammatory structure and you have fibrotic structure. Inflammatory structure, typically we use a balloon dilatation first, but however, you have the risk of the bleeding. And the risk of bleeding, how to control the risk of bleeding associated with dilatation? I use 50% glucose spray, 50% glucose spray. And this we use needle knife to treat the fibrotic structure, okay? Now, a lot of the people mentioned about it, you can use either CT scan or the ultrasound to differentiate the fibrotic inflammatory structure. Here is said, they said inflammatory structure. Here they said fibrotic structure. This is the slide I borrowed one my friend from Mao from China, and that group did a lot of the study. But as a lay person, I cannot tell it's an inflammatory or fibrotic between left and right. So now this group also use the ultrasound to differentiate the fibrosis or versus the inflammation. If the bluish is the inflammation, if the little bit of dark, it is related to fibrosis. And then unfortunately, transabdominal ultrasound is not widely available in the United States, but Europe and the Asian, a lot of the countries do the ultrasound for the differential diagnosis between the fibrotic structure and inflammatory structure. Now, this one is that we tell it's an X-ray or even endoscopy can tell it is the patient has a pre-stenotic dilatation or not. It's a lumen is dilated proximal to the structure. Typically, the people with the structure like this, you need a surgical therapy. You don't waste the time for endoscopic therapy. So 3 main modalities for structure therapy. One is a balloon dilatation, other one is a structurotomy or structuroplasty. Here is not a surgical structuroplasty, here's endoscopic structuroplasty. And occasionally we use a stent, okay. So actually, if the host, Magda or Luiz, if I'm over time, and please let me know. So here is a balloon dilatation. Here we use a knife to cut, and here is a stent. This is called axial stent, used to treat a very short structure. And I tell you, go slide by slides. So here is the summary of the balloon dilatation of the Crohn's disease structure. What's the main message? Main message is here, the maximum balloon size should be 18 to 20. So the smaller balloon, like 13, 15, for the esophageal structure, is not work here for the IBD structure in the gut. You need to use a larger balloon, or at least this is the final goal. You may take the several sessions to achieve that 18, 19, 20 size. The 25 is from Italy. They have the larger balloon. And then clinical efficacy success, that means how to measure it. You do the balloon dilatation, and after balloon dilatation, you were able to pass the scope through the structure. We call technical success. And then main complication, it is the bleeding and the perforation. Roughly the bleeding is about 3 to 5%, and perforation is about 1% to 2%. Now, here's we did a study of ileocolonic and asthmatic structure. We compared the surgical approach with endoscopic dilatation. You can see the surgery has advantage is when we compare the surviving curve. So endoscopy, of course, is a disadvantage. However, so by periodically do the endoscopic balloon dilatation, you may save average 6.5 years for the next surgery. 6.5 years for the people would need like a lifelong 1 or 2 surgery, not a big deal. If the patient need multiple surgery lifelong for Crohn's disease and 6.5 years, it's a big deal. In addition, and we also showed if the patient had a pre-stenotic dilatation, you see this 2 curve is separate even more. That indicate surgery is way better than endoscopic dilatation for the structure with the pre-stenotic dilatation. So if you have the pre-stenotic dilatation like this, you try to go to the surgery. Now, this is the key slides. That time we measure the complication rate. Endoscopic therapy roughly about 1%, and the surgical therapy about 8%. Okay. Now, this is called a primary structure. If the people with a disease-associated structure, for the Crohn's disease, mainly small bowel structure, and then you can see the 2 curve widely separate. So that's why initially I do a lot of the balloon dilatation for primary structure or disease-associated structure. When I see our data like this, I say really kill my appetite. For this, therefore, for the primary structure, you can try a few sessions. If the patient had a quick recurrence, you know what? Send for surgery. Don't waste your time for balloon dilatation. But however, this one, we developed the endoscopy therapy, use knife, give it a try. But a balloon, don't waste your time. Okay? So now you compare the balloon dilatation with resection in primary Crohn's disease, the complication is roughly around 1% versus 24%. Yes, surgery is more definitive, but however, the surgery associated more complications. The patient should know. These are the very important slides. Actually, when Dr. Lee was at Cleveland Clinic and with our group, we did a study together. So if the patient had Crohn's disease and asthmatic structure, so you have 2 options. One option, it is endoscopic dilatation, balloon dilatation, versus the upper front surgery. Now, so if the patient have failed balloon dilatation, they required a salvage surgery. The failed balloon dilatation, as compared upper front surgery, if there's a surgery needed, surgical complication is much higher in people with the salvage surgery who failed endoscopic dilatation. So endoscopic dilatation, be careful. If you failed, ended of the surgery, those patients tend to have this high surgical complication. Therefore, you identify the candidate patient is important. So this is called a nomogram. Typically, the nomogram this comes from multivariable analysis. You can see collect all the point. You put all the study important variable into the left column, and you calculated all the score, and then you can calculate the risk. So for example, if the patient had a pre-stenotic ileodilatation or primary ileodilatation with a primary structure, and if the patient had the previous operation, if the patient had a short interval from the last surgery, and the patient had a high risk for disease recurrence, and then surgical complications. So that's why if those patients have those risks, you probably not send it for endoscopic therapy. You may send the patient directly to surgical therapy. So now this I showed the tool. So we have a needle knife and we have IT knife. This knife, the cost about $100 to $120. This knife, the cost about $500 to $600. This has a ceramic tip, to prevent the puncture of the bowel wall. And then same setting, this one is more powerful than this. This one is we call it IT knife, is safer. So we use these 2 knives to treat. So give the example. For example, the patient had an asthmatic stricture at the ileal pouch anal anastomosis, and the structure has a staple. Now look at the balloon dilatation. Actually, these are the same patient. The balloon dilatation, you can see the tear. The tear is at the left side of the body. Keep in mind, if the patient put in left lateral position on endoscopy, so the 5 to 6 o'clock is anterior wall, and 11 to 12 o'clock, 11 to 10 o'clock, it is posterior wall. So you never touch this area because next door is a sex nerve, prostate, and vagina. You don't want the patient to have this, the procedure and the result in the vaginal fistula. So that's why when you do the balloon dilatation, you do not have luxury to decide how deep you tear, where to tear. Okay, so give you example, same patient with a stricture, with balloon dilatation, how traumatic it is, versus with electric incision with the needle knife, and you can see it very clean. We try to only cut the posterior wall and spare the anterior wall. So now also, sometimes you can tell the stricture is in mesentery or anti-mesentery site. Sometimes you try to the anti-mesentery side because you try to prevent the patient has a perforation leading to the mesenteric abscess. So here is two conditions. For example, if you have a tear here, balloon dilatation or knife that causes perforation, if you perforate it into the mesentery, then you can have the mesenteric abscess. Mesenteric abscess can result of the long segment of the small bowel resection. It's dangerous. Now, if you have a free perforation, if you happen to be free perforation, so you have a peritonitis. But however, bowel resection segment is shorter. So if you pick the evil and the devil, you rather the people have the free perforation rather than mesenteric perforation. So that's why when we do the balloon dilatation, you cannot decide, cannot control where to perforate. So you said it's a perforated here, maybe peritonitis, if it's perforated here to the mesenteric abscess. But however, when you do the needle knife therapy, you may have a control because sometimes you can tell if the mesentery side typically has ulcer here, then if you cut this side to prevent the mesenteric perforation cause abscess. So this actually, the endoscopy itself is not difficult because the key things you need to control the motion of the tip of the scope. You need to know where to cut, how deep you cut. Okay, now here's an example. For example, the patient had ulcerated stricture. Normally, ulcerated stricture, if you use a balloon dilatation, that can cause the major bleeding or even perforation. But with the knife, you can cut the non-ulcerated area selectively, say here. Then after cut, you put the clip there. But here, the clip main purpose is not prevent the bleeding or prevent the perforation. Actually used as a spacer. You cut that area, the tissue is off, you put the clip in between to keep the stricture open. Used as a spacer. Okay, so now here is a show the stricture here with the anastomosis. Here's the staple. Now when we do the needle knife, you cut the back wall. I use a green light. And these are so close to anus. Basically, you cut the direction. It is almost sort of like the circumferential to avoid the damage of the anal sphincter. So circumferential cut like this. And you only cut the posterior wall. You do not cut anterior wall. That can avoid the perforation and avoid the fistula of formation in the to the vagina, and avoid the anal sphincter damage. Now, here's the terminology, actually, because United States, we are a capitalist country, so that we all related to reimbursement. So when we do endoscopic therapy, we give it a name. So the name here, electric incision, that means your action of a cut. Use knife to cut. Structurotomy, you cut off the structure, cut, make a structure open. If you have a structuroplasty, that means you equals to structurotomy plus the spacer. So you have the different reimbursement code. Now, even our group had the consensus, we give the full name. It's a endoscopic structurotomy and it's endoscopic structuroplasty. So you can, in the future, you can quote these two terms for your reimbursement purpose. And then don't let the people feel like a panic when you say, oh, Dr. Shen treated a structure, I saw the clip. He must already have the perforation. No, it's actually, it is, we use it as a spacer. Later on, I showed the more picture. For example, this one we cut, just only action is cut, make the things open, right? This is called a structurotomy. Next one, we call a structuroplasty. Basically, there's a structure here, you cut, and it wide open, right? You put the clip there as a spacer. The clip will fail off the few weeks, and then structure already open, okay? The clip is a prevented structural reformation, okay, as a spacer. Now, when we compare the balloon dilatation with the needle knife, actually, you would say the structurotomy, actually the curve numerically is better than needle knife, than the balloon dilatation. And the complication I need to point out, it is so main complication for balloon dilatation is perforation. Main complication is for the needle knife, electrical incision, it is bleeding. Commonly is delayed bleeding. So after we changed the setting recently, if you use ERB, use a 313, and then the bleeding risk is much less, okay? But however, bleeding easy control, worst case blood transfusion, redo endoscopy, but we do not have a perforation, okay? Now, this the patient will be ideal patient. People have like the structure here, and then we use knife to cut to prevent surgery. So we compared actually a needle knife therapy versus surgery. You know, with the surgical approach, you redo anastomosis or treat the structure endoscopically. So this is the curve. You can see the two curves almost merged, and then P is 0.24. So the result of the surgical therapy versus endoscopic structurotomy or structuroplasty for cloned this anastomotic structure, the result is comparable. But the important one is complication rate. For the endoscopy therapy, major concern is bleeding. We only have the one patient with a perforation, I believe, and then the surgical complication rate here is 32%. Use this Cleveland-Dindo classification, okay? Now, why some of the structures so tough to treat? Very important concept. So sometimes the structure is primary structure due to the chronic inflammation is harder to treat. And some of the structure due to the pre-stenotic luminal dilatation has been the structure for a long time. And people had the multiple structure and the long structure, the harder to treat endoscopically. But here I want to point out next time if you see there's a harder to treat structure to make sure those patients do not have a proximal prolapse. I show you some of the picture. So this the structure, we're happy we treat. We're about to take the scope out. The prolapse, the proximal bowel. The mucosa prolapse blocked the treated structure again. See, the blocked. Now you cannot use knife to treat. You cannot use balloon to treat. Now, how do we treat? Actually, if you have the prolapse here, after you treated the structure, you can use esophageal banding kit. The band the prolapse component. That can help you the efficacy of the endoscopic therapy for the structure. For the tough structure, especially short structure, you may try the axial stent. It works well, especially people have a side-to-side anastomosis with a short structure. So now the next slide, I summarize endoscopic therapy, mainly balloon dilatation, structurotomy, structuroplasty, surgical therapy, you have a surgical structuroplasty, and the resection and osmosis. Each and pro and cons. Endoscopic therapy is not as invasive, but less decisive. But however, endoscopic therapy is it's easy to perform and a low complication rate. Okay, you can choose between the surgery and endoscopic therapy. If you have I encouraged all the gastroenterologists, IBD specialists, and the colorectal surgeon should at least know how to do the balloon dilatation. Okay. Now, Magda, do we have time more? If I have time, I can have more slides.
Yeah.
Okay. You want me to do more?
No, keep going. Keep going.
Keep going. Okay.
Keep it going.
Okay, keep going. Now it's a fistula and abscess. Okay, fistula and abscess. So the second category of the indication. So rule it is, so as a gastroenterologist, when we see anything inside the bowel, we find a hole. Our instinct would be put a clip there, close it. Not necessary. So that actually, if you have the fistula, if you have a chance, you can open the fistula. Open fistulotomy, always the first choice. Drainage, second choice. Clip is the last choice. Okay? See if you can do the fistulotomy. I can tell you, this is the pouch fistula. You can see the Y go through it. Basically, you treat the take the fistulotomy endoscopically. And again, our friends clips here. Clip here is not for control bleeding or prevented perforation. The main purpose here is the spacer. We don't want your cut area is reformed again. Okay? It's like you catch fish. You do the fish fillet, you need to open wide. Okay. So show the slide again. Here's another fistula to fistula here, and you just let things open. Okay. We use a lot of the guide wire, see the detect the thickness of the fistula and length of the fistula. Typically, if the fistula 2 centimeters deep and 3 centimeters long, short length, you can do the endoscopic therapy. I show the picture. For example, so again, no inflammation, no structure, no fistula. Now here is the Crohn's disease, very tight structure at ileocecal valve. Over the years, people formation of the fistula, ileocecal fistula. Now, if you detect this type of the fistula, you can do the endoscopic therapy, basically remove everything here and put a clip there. And then basically you save the patient had a surgery. Okay, so this is endoscopic fistulotomy. So we published article 2018, and that time we have some 29 patients that various kind of the fistula. Actually, what we found out, it is the confirmation of the healing, almost 95%, 96%. Complication rate is very low, very low. One of the patient had the bleeding, one of the patient has a blood transfusion. So it's a very good technique if you have a right indication. Now, Luiz may not like us to do that, right? Because we will take care of the business from our surgeons. Because actually, when we do in the endoscopy area, if we found abscess, found a fistula, actually we can put a seat on there ourselves. We can use the endoscopic guidance to put the seat on. Of course, it's like normally it will be done by correct surgeon in the OR, but however, we can do in the endoscopy suite too. So now, next slide, I show you this, how do we put it? There's abscess there. We try to cut, and then drain abscess, and we introduce the guide wire, and then we put the scope through it, grab the tip of the guide wire, pull out, and then introduce the C-town. Introduce the C-town. So the gastroenterologist also should know how to take the surgical knot. Like here, then we put the C-town there. Now, as compare our surgical approach, right? You have the probe here. Now, it's a very barbaric, right? We are, this is called a civilized way. This is a barbaric way, okay? So hopefully, like people can appreciate. So, but however, our surgeon, we are working as a team. We work together. Sometimes the people have the psoas muscle, very hard to drain because there's a bowel wall in between. You cannot drain. This is related to anastomotic leak. And in that sense, you may put the stent through the bowel to drain the abscess to inside of the bowel. Okay. Now here is an endoscopy treatment of fistula abscess. If the people have a stricture, we use a balloon dilatation or structurotomy, treat the stricture. If the fistula is a superficial, and you can do the fistulotomy. If the people have the bladder fistula, vaginal fistula, this need a surgery. People with abscess, you can try incision and drainage endoscopically, or you can put a pigtail stent, or you can put a ceton. Now, how about a surgical leak? Surgical leak is like our surgeon help us as a backup. In this setting, we also as a backup for our surgeons. So here is my main tool. You can tell you is that we have the various kind of clips. These are called endo clips, and these are called over the scope clips to close the leak. This is the stent, and this is the CT guide wire, and so this is ceton. So this is the tool we commonly used. So for the people have the colorectal anastomotic leak, very big leak. If you try this, the small clip, if it doesn't work, you can use the bear claw large clips. This one, it is a cost about with the anchor with a clip about $1,000 United States. This one, each clip about $150. Okay. So now regarding the pouch, actually pouch is a man-made organ involved a lot of reconstructions, and there are some weak spots too. For example, the common things that people have the tip of the J leak, the presacral leak, and the vaginal fistula. Some people have the middle pouch leak. So as an endoscopist, you can help for treat those leaks. For example, if the tip of the J leak is tiny, you can use small clips. If the clip leak is very big, you can use a bear claw. You use bear claw over scope clips. And then we published an article in 12 cases, and we tried actually success closure during endoscopy almost 100%, but the long-term success rate of all the things together is about 66%, and still 1/3 of the patient required surgery. But however, the procedure, endoscopic procedure, with 2/3 of them helpful in the long term, why not try? Because it's a 20 minutes procedure. Okay, here it's like the follow-up time like this. Now this presacral sinus is a common enemy for colorectal surgeon. Basically, this is a surgical leak here, either from the pouch or people from the colon cancer resection or rectal cancer resection. Similar concept. So basically, when you have the pouch here, you have a leak here, there's opening here, and then when we do the endoscopy, we cut that wall between the sinus and between the pouch body and incorporate the sinus body into the pouch body, let them become the part of the pouch. So these things become part of the pouch. I show you an example. This is the presacral sinus again at the 10-11 o'clock is the posterior wall. You use the knife to cut, open things up, put the clip there at the spacer. And then when you follow up, the cavity was covered by epithelial cells. Basically, you can cure. Now, regarding these things, the surgeon may try to redo pouch versus with the endoscopic therapy. Actually, we did a study on that. Basically, if the surgery-free survival compared the endoscopic therapy with the redo surgery, that is comparable. At that time, we have 141 patients treated with endoscopy, 85 patients treated with the surgical redo. But however, recurrence-free survival actually is sort of like a trend endoscopic therapy better. But this is the key concept. You talk about the complication rate. So here, like the 5%, and here is around 43%. So that's why those patients, we will recommend that you try the endoscopic therapy. You have nothing to lose. Okay. Worst case, if endoscopic therapy doesn't work, then you send it for surgery. Okay, because the complication rate is hugely different. Okay. Now, last one is we said it's an endoscopic ablation of the dysplasia. Today I did a case on that. It's like very hard to remove we call it colitis-associated neoplasia. Colitis-associated neoplasia, because the fibrosis, submucosal fibrosis, make the EMR and ESD difficult. Look at this is my failed EMR. inject, you sort of like raise the tissue, you try to grab it, it's very hard to grab. So you left the disease not treated, and it can be dangerous. Then even with the EST, you completely remove the tissue, but we really don't know the risk of the precancerous condition outside of that area has oncology, harm. So this is my last slide. Goal of endoscopic management is delivered therapy. The therapy is more definitive than medical therapy, but less invasive than surgery. And then in most of patients, we may defer or avoid surgery. It is important to know the indication and the contraindication. Endoscopic balloon dilatation, mainly probably for the anesthetic structure. If the people had the primary Crohn's disease structure, we put a question mark. You may give it a try of a couple of sessions. If people have the quick recurrence, you need to send it for surgery. For the recovery, refractory anesthetic structure, and then you consider it's a concurrent prolapse or other component. And we need further perfecting the endoscopic structurotomy and structuroplasty. Regarding the fistula therapy, if you have a candidate patient, try the fistulotomy first and drain abscess. The clip is the last resort. We do not use the clip to treat the primary fistula from Crohn's disease. This fistula typically, if you want to clip the surgical leak, not the primary Crohn's disease associated fistula. Sinusotomy for presacral sinus should be the first choice for the people with the pouch-related presacral sinus or colon cancer associated presacral sinus. Now, rule of endoscopic ablation in colitis-associated neoplasia, or I put a question mark here. This is my last slide. I dedicated this theory to my mentor and my hero. The right side is Dr. Fazio. And to take this time, I was just a young faculty at that time, 2002. And this is the OR. And this is the Marlene, this is Dr. Fazio, beer head, and this is the great man. And also I thank him for years. He taught me the surgical technique and the surgical principle as the gastroenterologist. I thank you. I'm happy to stop here and then happy to answer any questions. Thank you.
Thank you.
Thank you very much, Bud.
For amazing lecture. Can we start with the questions from the audience? Luiz?
Yeah, hi, Bo.
Yes.
We have one question, actually from one of our colleagues, Dr. Fabio. He want to know if when you are considering a sinusotomy for a presacral sinus, does the length of the sinus matter?
That matter. Actually, the sinus, there are several kinds of sinus. Your best sinus, like I show you this one, we call it L-shaped sinus. What's this? We call it L-shaped sinus, like a leak is here and up arm is here. No matter how long, you may take the several sessions to cut the sinus. But where's the case happened, if you never have these things before, you will have it in the future. What happened, people had a fistula from the tip of the J to anesmosis. It's like a large, so the sinus extended to the tip of the J. Then you cannot cut the pouch in half. What you needed to do, in that case, you clip the tip of the J to the half of the sinusotomy. As long as the opening of the sinus open, patent, you're safe. But this is called L-shaped sinus, but sometimes people have the T-shaped sinus. You have the leak here and another arm to the buttock. Now you need to put the C-tongue to the other arm of the leak and put the sinusotomy here. So, but these things, the length doesn't matter. Again, length doesn't matter. The shape. If the L shape, like here, L shape, it's the best to treat. Now also there are some other form. For example, say the I shape. If the sinus look like this, perpendicular, then it's very hard to treat. Okay, so for the like the 7-8 centimeters long L shape, you're your best friend as an endoscopist.
Okay, there is one more question. What about the sponge? Do you use endoscopic sponge for low colorectal anastomosis sinus?
Yeah, so all the sinus, this chronic cavity, right? Sinus is a chronic cavity, but a chronic cavity already wore off, already had a war. Now, if you sponge, people already had the war, sponge doesn't work. Sponge work for acute leak. So within two or three months of the leak, you can do the endovac and sponge. The acute leak. The sinus is chronic leak. Chronic leak doesn't work. Does not work.
Okay.
One more
Thank you very much, Bo. I want to ask Bruno to talk a little bit. Thank you very much. Bruno.
I cannot hear you well. Yes. Go close to the microphone.
I'm just saying thank you very much, Bo. And now I'm going to ask Bruno to talk to everybody. Thank you.
Okay.
Dr. Bo.
Thank you.
Dr. Bo.
Yes, I hear.
I have one more question.
Sure.
How do you use glucose in your procedures?
Okay. So glucose is a hyperosmotic the agent. So I use a lot. During the procedure, if you have a balloon dilatation or needle knife that cause the bleeding, as long as not pulsatile bleeding, is oozing type of bleeding due to the inflammation, concurrent inflammation, or the mechanical force of the tear. If you have the bleeding, you just spray the blood glucose 50% top of that. And also I use glucose to treat diversion pouchitis, diversion proctitis. Also I inject, if the people had a perianal fistula, long thin fistula, I inject the glucose through the fistula tract. For the people with a simple long fistula, perianal fistula, it may work.
Okay, thank you.
No side effect, no side effect.
No side effect? Okay, thank you.
Okay.
I think we'll finish, okay?
Thank you very much.
Thank you so much, Bo.
Anytime.
Okay, thank you.
Thank you.
Thank you.
Thank you. Bye-bye.
Bye-bye, Bo.
Bye-bye, Bo. Thank you. See ya.
Thanks, Ned.
I would like to thank you, Dr. Chen, on behalf of our society for the excellent presentation. It was great. You help everyone here, okay?
Thank you. Thank you, Bruno.
Dr. Lobato, pela participação. Agradeço os parceiros da Nestlé pelo apoio aí durante das nossas SMCP virtuais. E eu convido todos vocês para seguir o nosso canal do YouTube. Nós temos todas as aulas que têm acontecido na nossa SMCP virtual no nosso canal, então isso ajuda a que outras pessoas tenham acesso a esse conteúdo científico. E a partir daqui a 2 semanas nós teremos um novo encontro sobre DST com o Dr. Sidney Nadal. O Dr. Sidney Nadal é presidente da Sociedade Brasileira de Coloproctologia. Nós teremos a moderação da doutora Alice Capobianco, titular da Sociedade Brasileira de Coloproctologia também. Então, gostaria de contar com todos vocês, é um prazer tê-los conosco e vamos juntos daqui para frente. Até lá.
Okay.
Thank you. Good night, everyone.
Thank you. Take care.
Take care.
Send my regards. Stay safe and stay strong. Okay. Stay healthy, everybody. Take care.
Thank you, Paul.
Bye-bye.
See you tomorrow.
See you tomorrow.
Okay, thank you, everybody.